How's it going, guys? It is 8:33 p.m., 16th of May here in Japan. We have a medium difficulty question for pulmonary step 1 internal medicine surgery 2CK. Before we get started, please subscribe to my channel. Really appreciate it. Give it a like. Really appreciate it. Find me on Instagram, mehlman_medical, mehlman_medical. Links down below. Telegram links to the Telegram group and channel are down below. Now start the clip. 59-year-old man, 6-month history, progressively worsening dry cough. Vitals are normal. Auscultation of the chest shows fine wheezes bilaterally and allowed P2. Jugular venous pulsations are 3 centimeters above the costal margin. Chest X-ray shows reticulonodular pattern, which the following is most likely diagnosis. So various findings here, which I'll talk about as we move through the question. Choice A, cor pulmonale, wrong fucking answer. Now, the definition of cor pulmonale is right heart failure / right heart decompensation secondary to a pulmonary cause. Your left heart must be normal. So, for example, COPD due to smoking, cystic fibrosis, pulmonary fibrosis, whatever the cause originating in the lungs, if you get evidence of right heart failure, we now call that cor pulmonale. So let's look at the vignette here. Jugular venous pulsations are 3 centimeters above the costal margin. This is normal. Okay, so some of you are like, oh, I thought that was JVD, jugular venous distension. No, this is normal. And I did this because this is what nbme will do. So some students think that the fact that they mentioned 3 centimeters, no, that's normal, okay? So if we had JVD, peripheral edema, okay, hepatosplenomegaly, right heart failure findings in the setting of pulmonary disease, then that's cor pulmonale. But we don't have evidence of right heart failure here. Allowed P2 in and of itself is not cor pulmonale. Wrong fucking answer. Choice B, cryptogenic organizing pneumonia, aka bronchiolitis obliterans organizing pneumonia. Wrong fucking answer. So, as I've talked about in my prior content, when you don't know an answer, don't choose weird sounding shit. Okay? I don't think I've ever seen this as an actual correct answer on any nbme assessment. I've seen it float around as an incorrect / distractor answer, sure. But in theory, this is just going to be a patient where it sounds like a pneumonia. Okay, they can get fever, they can just have an ongoing chest-like infection appearance on x-ray, maybe a lobar infiltrate, etc., and it has no response to antibiotics. Okay, that's part of the history. Multiple courses of antibiotics don't ameliorate the condition, don't mitigate it. So that's in theory what COP or BOOP is. Wrong fucking answer. Choice C, interstitial pneumonia, wrong fucking answer. So just another name for atypical pneumonia, e.g. Mycoplasma, Legionella, Chlamydia, or viral, right? So we just have too much going on in this question here. If they just gave you a 24-year-old dude who he went hiking 8 hours yesterday, so walking pneumonia, right? He's otherwise healthy, and he's got a low-grade fever, 100.5 Fahrenheit, and then the chest x-ray shows bilateral interstitial infiltrates. That's mycoplasma, right? And you can sometimes get a low hemoglobin due to cold autoimmune hemolytic anemia. Mycoplasma can cause cold agglutinins. Wrong fucking answer. Choice D, sarcoidosis, wrong fucking answer. So, I mean, age range, slightly older for sarcoidosis, 20s to 40s, African-American female, very buzzy. Of course, that need not be the case, but it's buzzy. And chest x-ray would show bihilar lymphadenopathy. Okay, that's very buzzy. They can sometimes obfuscate it slightly. Say chest x-ray shows bihilar nodularity, OMG. Okay, but you can sometimes get a fever with it, erythema nodosum, redness of the shins, paniculitis, inflammation of subcutaneous fat. And obviously sarcoidosis, for you guys studying for step 1, you need to know that hypercalcemia that you see is due to non-caseating granulomas within pulmonary parenchyma, secreting 1-alpha hydroxylase, increased 1,25-D3 synthesis, increased small bowel absorption of calcium. Wrong fucking answer. Choice Z, usual interstitial pneumonitis, UIP. Correct answer. Now, if you followed my content, you've gone through my YouTube playlist here, I've harped on this. Not a big deal, okay? This is another name for idiopathic pulmonary fibrosis. Holy shit. It's not me being an asshole. This is on the nbme exam. Throw students for a curveball. They haven't heard of UIP before. You look up the Wikipedia article on this, they'll talk about like 50 different conditions in theory this could refer to. But what USMLE wants you to know is that when you just see this in isolation, you need to think of it as synonymous with just idiopathic pulmonary fibrosis, okay? Which is the answer here. Now, this chest x-ray finding of a reticulonodular pattern is extremely buzzy and pass level. Okay, I said it's a medium difficulty question, but this descriptor right here, a reticular pattern on chest x-ray, reticulonodular pattern, that means honeycombing, okay, which means pulmonary fibrosis, all right? So don't confuse tangential, don't confuse with reticulogranular, which can be seen in NRDS in premature neonates. But reticulonodular, or just reticular is going to be honeycombing for pulmonary fibrosis. Loud P2 just means pulmonary hypertension. 1 or 2 clips ago here on my YouTube, actually, I made a clip saying about how loud P2, loud pulmonic component of S2, and tricuspid regurg, okay? Those are the 2 main findings they want you to know for USMLE that mean pulmonary hypertension. So this just means pulmonary hypertension, loud P2. The USMLE can just say loud S2. There's really no loud A2 on USMLE. It's just loud P2. They can say loud S2. It means the same thing. Loud pulmonic component S2 or holosystolic murmur that increases with inspiration is tricuspid regurg. And then the auscultation of the chest. I've seen numerous findings, miscellaneous wheezes. I've seen crackles as well, which is slightly audacious because that can sound like pulmonary edema. But this question here is very buzzy, just the reticulonodular pattern, as I said, and then we've got evidence of pulmonary hypertension, but no overt cor pulmonale yet. USMLE wants you to know that idiopathic pulmonary fibrosis, it's going to be a patient over the age of 50 with a 6 to 12-month history of a dry cough. You know the deal. I'm going to make more content. If you like my stuff, subscribe my channel. Appreciate your time. That's it.